Welcome to Around Ocean County on 100.1 WJRZ. I'm Lisa Anderson. Joining us this morning, Dr. Mark Krasna. Dr. Krasna is the Medical Director for Meridian Cancer Care. Good morning, Dr. Krasna.
Good morning, Lisa, and thank you again for having me.
Oh, we're happy to have you. So much going on with Meridian Health and partnering with Rutgers Cancer Institute of New Jersey. And we're going to talk about expanding personalized treatment offerings to patients who have poor prognosis cancer diagnosis. And this is really exciting news. Let's first of all, your job as Medical Director for Meridian Cancer Care. Where exactly is your office?
No, sure. Well, thank you. I'm currently based at Jersey Shore University Medical Center, but in my role as the corporate leader for all of cancer care for Meridian, I try to spend a day a week at each of the Meridian hospitals. As you know, we have recently announced a over $128 million expansion of cancer services through Meridian. So it's a very exciting time, literally at each of our 5 hospital campuses and at our new freestanding facility at Jackson Health Village. Cancer services are really going to be ramped up and renovated and have the newest technology and the newest facility. So it's a very exciting time for my job.
Yeah, it's a very exciting time for the Jersey Shore patients as well. Affiliated Jersey Shore University Medical Center, Ocean Medical Center, Riverview Medical Center, Southern Ocean Medical Center, and Bayshore Community Hospital, all part of this Meridian Cancer Care. You must be a busy guy. I take my mom over to the Jackson facility there for all new doctors. What a beautiful building that is.
It is beautiful. I actually said to my wife after visiting it that I just wished we lived even closer because they probably have the most beautiful gym that I've seen yet in all of the Jersey Shore with one of the nicest pools. I'm a big swimmer, and I would love to be in that pool every day if I could.
I know. I wanted to jump in when I was there. I checked out the gym, and it really is a fantastic place. And doctors, and it's brand new. When I say brand new, there are offices that are still being worked on. So, yeah, check it out if you're looking. People along the Jersey Shore in that area, all kinds of doctors, and it is a great building. And today we're going to focus on the Precision Medicine Clinical Trial, focusing on rare and poor prognosis cancers. Now, Rutgers Cancer Institute of New Jersey is joining forces with its system partner, Meridian Health, and they're going to offer patients with these rare forms of cancer or with cancer that no longer responds to standard treatment access to a clinical trial. Tell us all about this, Dr. Krasna.
Sure, Lisa. This is really a very exciting time for medicine, and it's obviously an extremely exciting time for cancer care. We're really happy and excited within Meridian that we're going to be able to bring some of the newest state-of-the-art technology in identifying unique ways to treat cancer patients to our patients along the Jersey Shore. If you think of the way we typically would approach cancer care in the past, we knew the diagnosis. Let's just say from my specialty, it was lung cancer. And then we would look at the stage. So we would determine if it was localized or if it was regionally advanced or if maybe it had already spread, what we call metastasized. And then based on that, we would either offer the patient a surgery approach or perhaps a combination because, we do believe in multidisciplinary cancer care. That's really the cornerstone of all of our cancer programs. So perhaps you would have your medical oncologist and radiation oncologist and surgeon, let's say, see that particular patient again, let's say with stage 3 lung cancer, and they would determine that the best thing for that patient would be to give them chemotherapy and radiation therapy, and then afterwards perhaps offer surgery. The problem is that even in the best of all worlds, even in that best circumstance where we were doing what we felt was an individualized approach and giving the patient really the consensus of 3 different experts on what we thought was best, unfortunately, as you know, probably as many as 40 and sometimes as much as 60% of patients would either not respond or might respond, but then afterwards would develop a resistant cancer. And that's really typical of the way cancer has been for years.
Yeah. It has been. It's kind of like I don't want to say, it's a tough sentence to hear. In other words, a stage 3 lung cancer, you're thinking, my odds aren't that great. What does precision medicine do in this case?
Exactly. So the challenge for us now is to try to go further individualizing the care of the patient based on the patient's, what I'm going to call, gene profile. So each of us has a fingerprint. If you go to the police or you go to get your identity checked, and we could identify very subtle differences from one person to another just on a fingerprint. So imagine that our genes have our own personal, I'll call it, genetic fingerprint. Probably it's the best way to explain it for patients. And really what that means is that, let's just say if you, God forbid, had stage 3 lung cancer and I did, although they both look, based on an X-ray and a CAT scan and all the usual ways, they look similar, and we figure, well, they're both stage 3 lung cancers, well, they should respond to the same treatment. But when you get down to not just the cellular level, but not just under the microscope, but actually look at the genes, what we find is that two different patients' cancers may have a completely different genetic expression of their cancers. That is what's so, state-of-the-art and so revolutionary. If you think it's literally only within the last 10 years that the Human Genome Project was, done, where we actually completely mapped out all the genes in the human being. I was part of a subsequent study called the Cancer Genome Project, where we began identifying in lung cancer and brain cancer and ovarian cancer all the genes that are the kind of signature for those specific cancers. What we're doing now with precision medicine is the next step. We're looking at the gene expression, and then we're taking the information from the gene expression, and then we're trying to identify, are there genes that are what we call actionable? And what that means is there a gene abnormality in this person's tumor, which we know we have a drug that we could use to target that specific gene. So that's really this whole next step on how we're going to approach cancers, and really eventually how we're going to differentiate the way to treat patients' cancers, not just based on the diagnosis, not just based on their stage, but actually based on what we'll call their genetic signature or their genetic fingerprint.
We are speaking with Dr. Mark Krasna, Medical Director for Meridian Cancer Care. Dr. Krasna is talking about precision medical clinical trial focusing on rare and poor prognosis cancers. The DNA makeup of each person, Dr. Krasna, really, it kind of changes the whole way that you treat your patients, doesn't it?
It does. So again, imagine that, this one patient's DNA expresses a particular gene abnormality. And I'll just use a good example because most people have heard about these terms. Let's just say there's something called HER2 expression. Well, HER2 or HER2-neu expression is a genetic abnormality that for many, many years we've known exists in women with breast cancer. It was very helpful because we had a drug called Herceptin that we could treat. So already for years, we had been treating women with breast cancer, as an example, on a more targeted basis, because if they had HER2-neu abnormality, we would give them Herceptin. There was also what's called ER and PR, or estrogen receptor and progesterone receptor. And again, we knew that patients who had ER or PR positive tumors, they would actually respond very well to targeted hormonal therapy. So the idea of giving a woman, hormone therapy or different kinds of hormone suppression was basically the first step in, I'll call it, targeted molecular therapy. Now imagine you have a patient with stomach cancer or cancer of the esophagus or lung cancer. And just as an example, let's just say that when you look at that patient's gene fingerprint, you find that they also have an abnormality in their HER2 expression. So all of a sudden, you now have the possibility of taking a drug that used to only be used for a different cancer called breast cancer, but now that drug has reasonable applicability in a patient, let's say, who has stomach cancer or esophageal cancer. That's the kind of changes that we're making, basically taking things that you never would have thought would go with this particular tumor because they'd never been used in that scenario in the past, and now trying to apply it. And that's just, I think, one example. Another level to think of this, and really part of what we're doing with Rutgers CINJ, which is the most exciting, is that our partners at CINJ obviously have access to experts in molecular biology. They also have access to experts in not just new drug development, but think of them as new molecule developments. These may be things that have been on the shelf with either an industry or in somebody's lab for years, and we really didn't know what the use was in treating patients, but we knew that there was a molecule, a formula that actually worked against a particular abnormality. Well, now we find that abnormality, that gene abnormality, is present in cancer. So what we're hoping with the precision medicine trial is that, Meridian patients with these kinds of rare cancers are then presented to what we call a molecular tumor board. It takes place once a week, and we have a patient presented. They discuss the patient with the clinicians, with the radiation oncologist and the medical oncologist and the surgeon, but also importantly, we have not just the pathologist and the radiologist, but also the molecular biologist. And then we'll have some of the other researchers who say, well, I have a new drug or a new molecule that's going to work against that abnormality, against that abnormal gene. Let's try that drug on this patient. And so now our patients will have access to very new, very recently developed drugs that may not even yet be approved for use in cancer, but as part of the clinical trial, we could use these molecules if the patient has a known target, a known molecular abnormality on their gene signature.
So all of this technology, all of this expertise is enabling all of you to really move beyond a one-size-fits-all approach when it comes to the treatment options for your patients to a personalized approach to cancer care, giving hope to so many. Dr. Mark Krasna joining us this morning. He's the medical director for Meridian Cancer Care. And when we come back, Dr. Krasna, I'd like to talk about examination part of it and how we actually go about getting these patients into this new, exciting time of cancer care. We'll be right back.
Thank you.
Good morning. We're back. I'm Lisa Anderson, and this morning's guest is Dr. Mark Krasna. Dr. Krasna is the medical director for Meridian Cancer Care, and we're talking about exciting developments, Dr. Krasna, with poor prognosis cancers and rare cancers. Let's go back. We were talking about how the DNA each individual person has determines new treatments, for example. What would you call a rare cancer?
That's a good question. So the kinds that we see, let's say, typically in the state of New Jersey would be pancreatic cancer, even some melanomas, and even some of the gynecologic malignancies like ovarian cancer. So as opposed to what you usually think of when you think of cancer, which would be prostate cancer, breast cancer, colon cancer, and lung cancer. Because this is still a clinical research study that we're doing with Rutgers Cancer Institute in New Jersey, the first part of the study is really going to be limited to those rare tumors. But as you mentioned earlier in the discussion, we're also going to include patients who may have more of the common cancers, but whose tumors have recurred despite, let's say, what we'll call first-line or even second-line treatment. So they've already had that attempt at the standard therapy. Perhaps they've already had, one or two of the different kinds of chemotherapy regimens or surgery or radiation, and now their tumor has recurred. Those patients would also be eligible. So really the first step, Lisa, that we will do is we'll actually draw a blood sample from the patients, and we'll also try to get a specimen, a sample of the patient's tumor. And then what we're doing is actually looking at the gene expression. So the very first thing is that an entire gene sequencing or a gene mapping is done. As I said, the genetic fingerprint of that particular patient's cancer. And then once we have that gene map, now we know of the literally thousands and thousands of genes that are there, which ones have abnormalities or what we call mutations. And then of those, which of the abnormalities have we identified that have a known drug or some other known formula that can work against that abnormality? And that's really the very, very first step. So the first step is we get the sample is studied, and we actually get the printout of all of those genetic abnormalities, and now that patient is brought, as we were saying earlier, is brought to that molecular tumor board where the patient is discussed.
You hear it all the time. For an example, again, a woman with breast cancer, 5 years cancer-free. Another woman has breast cancer, treated the same way. Her cancer returns in 2 years. So it definitely makes so much sense that the DNA makeup of each individual person is different, and maybe that's what causes some cancer to return in the same type of, say, breast cancer with women, and some women beat it for 20 years.
That's a very good statement, Lisa. Basically, what you're describing is the molecular behavior of someone's cancer. So although under the microscope they both may look like a certain type of breast cancer, and maybe they even on the CAT scan and on all the other studies they look like they're the same stage, but one patient's cancer is behaving differently than the other patient's cancer on a molecular level. And what we now know is that when we say molecular, what it really means is that there's genetic differences between the two cancers, and those genetic differences make some of the cancer cells respond differently than others. So again, we were saying earlier, let's say in breast cancer, someone has already had standard therapy with hormones, perhaps they've even had standard therapy with a drug called Herceptin against HER2/neu, but let's say that patient has now recurred despite these two prior therapies, and now this cancer seems to not be responsive to the standard therapies that we've had. By going deeper down into the level of the actual gene sequencing and identifying where the gene mutations are, we're hoping that we could identify what are those molecular or biologic differences in that patient's cancer that's making it act so much more virulent, so much more aggressive than the other patient's cancer.
I understand individuals 1 year old or older who have been diagnosed with rare forms of cancer or a cancer that is no longer responding, eligible to participate. And we'll tell our listeners how in just a moment. But they take children 1 year old and older?
That's correct. Unfortunately, children's cancers obviously can be very aggressive. Luckily, in general, children's cancers are rare, so therefore they almost all will qualify for participating in a study like this. And again, the good news is that some of the what we call typical children's cancers in the past years, things like leukemias, we actually know a lot about now. We know a lot about their genetic expression, and we know in terms of what the gene abnormalities typically are and how to respond to treat them accordingly. But again, even there, a patient may have had a first-line or second-line therapy that you think would be enough to control that tumor. But again, if the patient then recurred despite that or wasn't responding to that first-line therapy, absolutely, even in children as young as 1 year of age, we would consider those patients for the precision medicine trial as well. And again, to your question about how the patients would go about doing it, so we basically have our clinical research associates at each of the Meridian Cancer Centers. So we have a research nurse or research associate at all of the cancer centers, at Bayshore Riverview, at Jersey Shore, at Ocean and Southern Ocean, and even now out at Jackson Health Village. That clinical research associate is there when the team sees the patient. They can identify the patient and make sure that the patient meets the eligibility criteria. And then if the patient does, then that patient would be referred to our colleagues at Rutgers CINJ. A specimen from their tumor, as well as a specimen of blood, would be taken and then sent up. And then, again, the patient's treating physician from Meridian would go up and be a part of our Rutgers CINJ molecular tumor panel and actually discuss the patient, present the case, and then we would hear the feedback from the molecular biology scientists in the room in terms of what other treatments are available for this patient that might be appropriate.
I know the last time we spoke, Dr. Krasna, we were talking about the support, the one-on-one support from the nurses at each of these centers, which yes, I feel is so important. Can you just touch on that again?
Sure, absolutely. And what you're referring to is our Nurse Navigator program. We're delighted that we now have 15 nurse navigators throughout Meridian Cancer Care. So really at each of the sites, there's now more than one nurse navigator. What we're trying to do is, as the programs grow, we're actually trying to have a specific nurse navigator for each disease site. So for instance, there was a nurse navigator for lung cancer, and there was a separate nurse navigator for breast cancer. And again, the reason is because those cancers are so common, we want them to spend as much time as possible with that team of physicians. The nurse navigators play a very, very important role. They are what I consider the glue that holds the team together. That multidisciplinary team that we have is your medical oncologist, radiation oncologist, and surgeon, and those physicians at Meridian Cancer Care really are working together as a team. They present each patient in a prospective multidisciplinary tumor conference. We have numerous tumor conferences every week. The nurse navigators are the ones who collaborate to get all that information together. And then once a consensus is arrived at in terms of the best treatment for this patient, it's really the nurse navigator, in addition to the physicians, who get back to the patient. We think of them as the go-to person. When the patients have questions, if something's not clear, if something has come up, they can reach out to the nurse navigator. And again, it's wonderful having a nurse navigator at each site. I will add, in addition to what we had discussed previously on the past interview, we now have also added a survivorship nurse navigator at each of the cancer centers. So now there's somebody whose job it is not just to help you through your cancer care treatment, but at the end, as you're getting to the end of the treatment phase, we know that there's this very important handoff point where the patient is not quite ready to get back into being a civilian again and getting back into the regular life because, the patient is concerned, well, what's going to happen to me? Am I going to be lost? Am I going to have follow-up? Will my doctors keep an eye on things? And really, the survivorship navigator is going to be the person to really try and help coordinate for that patient the long term, making sure that they get all the follow-up tests that are necessary, and also reminding the patient that, now that you're healthy and you've survived your initial fight against cancer, let's just say, don't forget, if you're 50 years old, you need to have your checkup. You need to see your cardiologist if you've had high blood pressure. You need to get your screening colonoscopy, even if you were a survivor of lung cancer. And the navigators from the survivorship program really is the person to help kind of give the patient that summary of all that they've been through and give them the follow-up plan for their cancer, but equally importantly, then tie that patient back to their primary care physician and make sure that they get back into their usual healthy preventative medicine, kind of all the maintenance that they need to do now that they're over their cancer scare. So we'll follow up for the cancer, we'll make sure you're not lost, and we know what your tests are, but don't forget, as a regular healthy person who's now over their cancer, you have all these other medical things that you need to pay attention to, and that's part of the important role of the navigator. Extremely,
extremely important, because it is a really scary time when you're going through all of the treatment, and it does change your life. When you hear that all clear, like you said, you're not ready immediately to jump back into the life you had. So what an important lifeline that is with the nurse navigators.
Yes, absolutely. And again, we think that they are an invaluable resource to our physicians, but most importantly to our patients along the Jersey Shore. Like I said, they are the people that will keep the patients tied in with all their physicians. They're the glue that also then puts the patients in touch with other resources if they need help, whether it's financial counseling or social work, or they need to see somebody for psychosocial support. All of those things, dietary involvement, and again, we're talking today about research. It's the nurse navigators that will often think of a research trial that this patient might be eligible for, and then call in our clinical research team to see the patient. So I think they're a very important resource.
What a great network of people. For additional information on how to participate, what should one do?
I knew you were going to ask me that. The best thing to do would be to contact our clinical research office and ask for information about the clinical research trial for precision medicine. And the number they should call is 732-235-8675. That would put them in touch directly with the clinical research associates at Rutgers Cancer Institute of New Jersey, or they can call directly to Meridian Health Cancer Center at whichever cancer center they're being seen, and then nurse navigator there will put them in touch with a clinical research associate at Meridian.
Is there a website, Dr. Krasna?
Yes, patients should log into meridianhealth.com/cancer and look under cancer care, and they can either contact directly the nurse navigator or the research office that is closest to them, or at the hospital where they're being seen.
Great news, Dr. Krasna, for the Jersey Shore, for folks that are battling cancer. And again, we've been talking with Dr. Mark Krasna. He is the medical director for Meridian Cancer Care, Rutgers Cancer Institute of New Jersey, joining forces with its system partner Meridian Health, offering patients with rare forms of cancer or with cancer that no longer responds to that standard treatment access to a clinical trial.
And I'll give you one other phone number if patients are interested, and that would be 732-776-2953, and that would put them in touch directly with our Office of Clinical Research. And then depending which hospital they're in, they will put them in touch with a clinical research associate sites closest to them.
Your help has been invaluable this morning, Dr. Mark Krasna. It's always a pleasure to have you on. Stop by again and tell us about all the great advances going on with Meridian Cancer Care, and together.
Someday we will stamp it out.
Yes, we will. Thank you so much, Dr. Mark Krasna.
Thank you, Lisa. Good to be with you again.